Hi guys, welcome back. The next topic we're studying is congenital heart disease. Here I'll be explaining to you the diagnostic criteria, then I'll talk about left to right sided shunts, right to left, and then subsequently the mixed effects as well. Let's dive into the data and study the important aspects first. First and foremost, just like you have studied Jones criteria, the modified ones and the modified Dukes criteria for rheumatic heart disease and infective endocarditis respectively, I want you to remember NADA's criteria for diagnosis of congenital heart disease, which are going to be subdivided into the major and the minor ones. Now, when it comes to the major one, first and the foremost is going to be congestive heart failure. Why? Because if a person is going to be having left to right sided shunt, then there will be volume overloading. And this volume overloading will contribute to right ventricular failure, overloading of the pulmonary circulation, which can not only cause pulmonary artery hypertension, but even result in recurrent pneumonia episodes. Though recurrent pneumonia episodes is not a diagnostic criteria, because obviously we're talking about a cardiac condition, I want you to remember that lots of questions of acyanotic congenital heart disease will begin by describing a child who's having recurrent pneumonia episode with features of right ventricular failure like a hepatomegaly or prominent neck veins or ankle edema developing. But if it's going to be a question which is going to talk about right to left sided shunt, then he might say cyanosis non-responsive to oxygen supplementation. Well, central cyanosis does not respond to oxygen anyway. Point number 3 and 4 are again important. Why? Because whenever there's going to be any shunting of blood from any chamber to any chamber, there can definitely be a murmur created. You will notice that in the textbook, diastolic murmur is given above systolic murmur. I'll tell the reason for that. You see, when it comes to systolic murmurs can occur due to hyperdynamic circulation as well. Let me give you an example, right? Suppose a child is having fever. Then because of fever, because the heart rate will increase, the hyperdynamic circulation will cause ejection systolic murmur. You give paracetamol or crocin to the child. When the fever will come down, heart rate will come down to normal, and the turbulence will decrease, the murmur will disappear. If you go to the murmur section in the app, I have said this statement: the most common type of murmur that is seen in children is called as innocent murmur. The message is that yes, systolic murmur is as important as a diastolic murmur, no doubt about it, but systolic murmurs can be due to physiological reasons like high grade fever or even anemia. An anemic child will be having a hyperdynamic circulation. He could be in compensated congestive heart failure, so you might be able to hear a systolic murmur. You treat the anemia component by giving packed RBCs, iron supplementation, folic acid, B12, depending on the etiology, the murmur will also disappear. Diastolic murmur is given more credibility over systolic because systolic can occur even due to physiological reasons and will disappear once. I would highlight like this: if a child is having fever per se, it is a hyperdynamic circulation which is contributing to it. Now, do remember in point number 4, he will also mention this statement, that is systolic murmur more than grade 3. I'll explain the grades also, though they're not important for the exam. I want to highlight the fact that when you read this word grade 1 murmur versus grade 2 and onwards, then grade 1 murmur is very faint murmur, so that can be heard only with the, let me say, the experience of a DM cardiology. But grade 2 murmur can be heard even with an experience of a MD medicine. Grade 3 murmur is what even an intern can hear, see. So at least it is appreciably loud. So the words are faint murmur versus loud murmur versus very loud murmur. In grade 4 murmur, even the patient is saying, I'm having a murmur. He may not say the word murmur, but he might put his hand on his chest and say, sir, I can feel some turbulence, because he can palpate the murmur. That is a thrill. So here, even the patient is telling you that something is wrong with his heart. He can feel the turbulence. When it comes to grade 5, in this case, in fact, I'll say a very surprising thing. You see, normally to hear a murmur, you need to place the diaphragm in contact with the chest wall so that you can hear the conducted sound. But in this case, the stethoscope is off the chest wall. Imagine the turbulence and the sound is so much. The sound is coming from the chest of this guy that even if you keep the stethoscope diaphragm 1 centimeter away from the chest wall, even then the sound will be conducted. So stethoscope off the chest wall would be one of, I would say, very loud murmurs. Per se, they are not interested in asking you the grading of the murmurs, because obviously in an exam they can't make you hear and tell you, okay, tell me the grade of the murmur. So this is just a theoretical information that can be a part of the MCQ. And why I'm highlighting it, or I could have avoided, is because in the minor criteria you will again read the word systolic murmur. The query of most doctors is, sir, you just told systolic murmur even for a major criteria. Now you're saying the same thing for minor. Well, the difference is less than grade 3. And at this juncture, I just want to say that in the exam, in a pressure cooker situation, that more or less can actually go wrong. So just get the facts right. I mean, more, the arrow is, towards a bigger side. So that's why it's going to be considered as a major criteria. Now you will notice abnormal word coming up again and again. The first abnormality that I want to bring to your notice is if I say wide fixed split second heart sound. I've told you wide fixed split second heart sound is a feature that is seen in ASD. Wide variable split is a feature seen with VSD. Or if I say single S2, P2 is not heard, only A2 is heard. Why single S2? Because if a person is having tetralogy of Fallot, then there is very less blood going into the lungs. If less blood will go into lungs, the valvular lesion, the pulmonic valve movement will be very less. If pulmonic valve will hardly move, P2 will not be heard, only A2 component will be heard. So whenever you read words like single S2, wide fixed split, wide variable split, that obviously gives credibility to the diagnosis, and that would be a minor criteria. If I say boot-shaped heart, that can definitely give credibility to diagnosis. So abnormal chest X-ray is also important. Then there are two varieties of ASD. One is ostium secundum, another is ostium primum. Ostium secundum has a right axis deviation, but ostium primum has a left axis deviation. I'll give the reason for that also, but I want you to remember that abnormal ECG will also give credibility to diagnosis. Now let us take up an obstructed defect like coarctation of aorta. If a person is having coarctation of aorta in the descending aorta, then blood going to legs will be lesser. So BP in the legs will be lower because less blood is going. But because of increased peripheral resistance, the BP in the upper extremities will be relatively more. So you will also read about abnormal blood pressure values. You can see this abnormal word has come up again and again with respect to S2, chest X-ray, ECG, blood pressure values. So I think the right hand side is relatively easier to remember. Now let us look at the diagnostic algorithm. Unlike Jones criteria, where you should be having at least two major criteria for diagnosis of rheumatic, here it is one major or it could be two minor criteria. Again, it is very simple at the moment, guys, but I've seen very brilliant people actually messing up between NADA's and Jones criteria. So please be very comfortable with these criteria per se. In fact, I would suggest you to just note them down in your own handwriting, put on a stick-on pad somewhere where you can see them again and again. And all these on the left-hand side are obviously important for diagnosis. Now, on the basis of all these parameters, let us first talk about what is going to happen if a person is developing acyanotic congenital heart disease. There are going to be three of them. That's going to be VSD, ASD, and a PDA. Though I have spoken about these three diseases even when I have discussed heart sounds, but this is giving me the opportunity to discuss them simultaneously. VSD usually presents at 6 weeks of age. Why at 6 weeks of age? Because initially the pulmonary artery pressure is substantially high. So therefore the shunting is very limited. But as the child will grow, then the pulmonary artery pressure will reduce and therefore the shunt will become very obvious. Patent ductus arteriosus can become symptomatic even at birth in case of preterm babies. If it is a term baby, then the symptoms will come at 6 weeks again because of the resistance in the pulmonary circuit. ASD is a low pressure shunt. The pressure difference is only as little as 4 millimeters of mercury. So ASD can present at 5 years of age. In fact, sometimes might become symptomatic even in adult age group. This is itself a question. Which congenital heart disease becomes symptomatic in adult age group? It is ASD. You can easily solve the question because in all three of them, features of congestive heart failure, especially of the right hand side, it can be left side also. Especially in like PDA, it's a left ventricle failure causing pulmonary edema, but CHF features with recurrent pneumonia episodes would be a standard feature that would be present in all of them. Now, abnormalities of second heart sound will definitely separate the question for you because when it comes to second heart sound, he can say wide split 2 times. Wide split can be discussed for VSD, wide split can be for ASD. But the fundamental difference is from VSD alphabet B, you can remember variable split versus a fixed split. Whereas when it comes to a PDA, because it is going to be left ventricular failure, this would be a narrow split second heart sound. Then the murmur will also do the trick in this case. When you look at VSD, the blood is leaking from the left ventricle to right ventricle, so pansystolic murmur. In patent ductus arteriosus, the murmur can be so loud that it will drown the noise of everything else. That would be a continuous murmur. In ASD, there is no shunt murmur. There can definitely be flow murmur, When I say flow murmurs, what are the flow murmurs in ASD? One of the flow murmurs can be that the blood will go from left to right atria, then from right atria to right ventricle. More blood is going in the right ventricle. So therefore, there can be a mid-diastolic murmur. Why? Because blood flows into the ventricles during the phase of diastole. And then this extra blood in the right ventricle has to go out into pulmonary artery also, no? Blood goes out into the artery, pulmonary artery or aorta during the phase of systole. So the flow murmurs that can be heard here are two of them. First, more blood will come in, that is during diastole. Then more blood will go out of the right ventricle into the pulmonary artery, that is ejection systolic murmur. Those are not shunt murmur, guys. Those are gonna be flow murmurs that are appreciated. Now, because of the fact that this information is so simple that even if you deliberately want to do this question wrong, it will never go wrong. So therefore, he will try to mix up some aspects of embryology also, which I'll jot down on the next slide. Like for example, he can mention the subtypes of ASD versus subtypes of ventricular septal defect. Well, you are very comfortable with the fact that the commonest variety of ASD is ostium secundum, but in Down syndrome cases, we get ostium primum. Now, there's an alternative terminology that examiners love to use for ostium primum, which I'm going to highlight before you. You will notice in MCQs written words like AV canal defect, or he can write a word endocardial cushion defect. What he means by this endocardial cushion defect is that there's a cleft, or I would say a malformation in the mitral valve leaflet. Endocardial cushion implies there's a defect with the valve leaflet, and this defect in the valve leaflet can actually cause left ventricle blood to leak into the left atria. That will cause gross dilatation of the left atria, and as a result of it, because left atria is substantially increased in size in ostium primum, therefore in ECG there is a left axis deviation. In ostium secundum, there is no cleft mitral valve. Left ventricle will not be able to send blood into the left atria. It is left atria sending blood into the right atria. So right atria will become bigger. So in ostium secundum, because right atria is becoming bigger, in ECG you will see right axis deviation. This point is always asked by students, sir, ASD is present in both of them. So why right axis deviation for one and left axis for other? The fundamental difference is ASD is a common thing in both of them. So obviously right atria should become bigger. But the problem in ostium primum variety is that there's a cleft mitral valve which will cause blood to go from LV to LA and cause a gross dilatation of LA right away. So therefore left axis deviation will occur, and later on, it can be biatrial enlargement also occurring in a case of endocardial cushion defect. There's a third variety also asked. This third variety of atrial septal defect is called as sinus venosus variety, and he will ask you this is associated with, so your answer will be PAPVC, that is pulmonary anomalous, not TAPVC, not total anomalous pulmonary venous connection where you have figure of 8 appearance. Pulmonary anomalous, that's a partial abnormal pulmonary venous connection. The word here is not total, it is partial, and the radiological finding is also different. In TAPVC, we always read about figure of 8 appearance, but in PAPVC, you will always read about Scimitar sign. In fact, for this Scimitar, you can even refer to the radiology component. So you can see that in the exam, he'll try to link up the embryology aspects with respect to axis deviation or with the radiological sign. Now, when you compare this information with that of ventricular septal defect, VSD is again of 3 types. He can ask you which VSD will always exhibit a or possibly exhibit a spontaneous closure. You see, muscular VSD, guys, is capable of closing at its own. So there is a possibility that you might have an educated mother telling you that, doctor, when my baby was born, I could hear some sound coming from his chest or from his heart, especially when the baby was sleeping, because the mother will be sleeping very close to the baby. She says, I could hear a sound coming from the heart of my baby. As he grew older, the heart sound disappeared. That was because the muscular VSD is the only one that can exhibit a spontaneous closure. In contrast, when it comes to the most common variety of a ventricular septal defect, we are going to call it the perimembranous variety. So do remember this aspect. The commonest one is perimembranous, but it is muscular that can exhibit a spontaneous closure. Then he can ask you one with a bad prognosis. Now, VSD is anyway bad, guys. I'm not disputing that. What I'm saying is in relative terms that if you're having a supracrystal variety of ASD with valvular aortic regurgitation, imagine aorta blood will also come back in the left ventricle, and all that blood is going to race into the right ventricle and pulmonary circuit. So you can understand the amount of volume overloading that's going to happen in the lung circuit and a substantial pulmonary edema that will occur. So because of the concomitant AR, the pulmonary edema component will worsen. So these are aspects of ASD and VSD from the embryology component that can be asked or can be added to this question. And when it comes to treatment, VSD might require a surgical closure using a Dacron patch. That will obviously be requiring that the interventricular septum be explored. But for patent ductus arteriosus, one of the good approaches, especially in preterm children, is indomethacin. That will help in closure, or ibuprofen can also be written. And if obviously drugs are not working, or if it's a term child, then in a term child, obviously don't answer drugs. If he says term child, if he says preterm child with PDA, give supplemental oxygen, wait for it to close. If it does not close, even with supplemental oxygen, because preterm babies are anyway having hyaline membrane disease, hypoxia will also keep the ductus open. But the moment you treat the hypoxia component and still it is functioning, then you can give drug. But in a term child, it would be definitely, I mean, endovascular techniques are available, or surgical intervention is definitely required. And in AST, we have a special occlusion device. This occlusion device can be introduced via the peripheral vein, via the basilic vein, and it can actually close the hole. And why we are using occlusion devices in AST is because it is a low pressure shunt, so the device will be able to hold its position, whereas the device will definitely get lost if it's gonna be a VST, which is a ultra high pressure circulation. I wanna highlight once again, guys, a lot of congenital heart diseases may not become symptomatic, especially acyanotic ones, may not become symptomatic right at birth, because at birth pulmonary resistance is still high. As the baby will grow, pulmonary resistance will fall. That is when the left to right sided shunt will become functional. So there is a possibility that VST was present right on day one of life. But why is it not becoming symptomatic on day one is because there is a high pulmonary circuit. The moment the pressure goes down, that is when the shunt becomes operational to the level that it causes disability in the child. And lots of time, I mean, why I am highlighting this now is, if you are having a mother who's saying, doctor, I think my baby is having a feeding problem. Like, he gets tired very soon. He leaves the breast after 2-3 minutes. Normally you would have seen babies have a pretty good or a voracious appetite, but she says, doctor, I find my child, one, is not gaining weight, and second, when he takes to the breast, after a few minutes he leave the breast. Then, I mean, I agree, there could be attachment issues. It could be primary gravida. She does not know how to feed the baby. So the baby will not be able to, take a proper breathing while he is suckling the breast. So definitely aspects of pediatrics, I respect them. But I want to tell you that always keep your mind open for the fact that, is there not a congenital heart disease? And whenever in doubt, get a echocardiography done. Because I've seen situations where, very highly placed doctors, they dismiss the mother saying, no, your child is fine. It's mainly attachment issue. Turned out later the child had a congenital heart disease, and that's going to be distressing both for parents and later on for the doctor. I would say it would be a little embarrassing to say that you dismiss somebody just like that and turned out to be congenital heart disease. So you need to have an index of suspicion. It's good that your suspicion went wrong. Suppose the echocardiography showed there is no congenital heart disease. I am comfortable with that. But on the other hand, if I dismissed a mother, especially a poor mother who says, no doctor, I think I am not able to feed my child, and he becomes very breathless, and I told her, no, it's a feeding problem, turns out to be a congenital heart disease later, then it would be a fairly embarrassing situation for me. Now is the turn for discussion of cyanotic heart diseases, and the first one on the agenda would be to talk about TOF, tetralogy of Fallot. There are 4 defects which are present here that I want to highlight, and lots of time in the questions he might ask you regarding triology of Fallot or even pentalogy of Fallot. The main fundamental problem, in fact this is itself a question, that which is the major determinant of cyanosis. Though in this condition there is a right to left shunting occurring via a VSD, if he asks you to select one, that what is the major determinant of cyanosis, your answer would be given as subpulmonic stenosis. Please appreciate that pulmonic valve orifice is just fine. It's useless muscle which is present just proximal to the pulmonic valve that will contribute to the problem of this person of less blood going into the lungs. And since there is a subpulmonic stenosis present right from day one the heart was developed, so they would be right ventricle having to do extra work, exercise much more than normal, and therefore there is a concentric right ventricular hypertrophy. The VSD in this condition does not operate from left to right but from right to left. How is it possible? I mean, that's the usual carry from a lot of doctors saying that, sir, left ventricle pressure is more than right, then how can blood go from right to left? Well, the reason for this reversal is primarily because this patient is already having more muscle in the right ventricle. More muscle in the right ventricle would mean that there is a possibility of the shunt having the direction that I've specified. Over and above this, contributing to the cyanosis will be overriding of the aorta. I'll draw a sketch highlighting the overriding of the aorta, but at the moment my main objective of explaining this topic to you is that he actually mixed up this information with that of triology of Fallot and pentalogy. For triology, subpulmonic stenosis will still remain the same. It will cause ejection systolic murmur. Concentric right ventricular hypertrophy will also remain the same, but now the change is coming. That is, there would be no VSD present, it would be ASD present, and obviously because it's a triology, there will be no overriding of the aorta. In contrast, if he talks about pentology of Fallot, then all the features of tetralogy of Fallot that I mentioned in color blue will be present, and along with that ASD would be present. So in pentology, VSD is also there and ASD is also there. The hallmark lesion among all of these, if he asks you to select one, I have already sensitized you to the fact that the major determinant of cyanosis is not to be answered as VSD. The major determinant is less blood supply to lungs, because after all, you see, blood has to go into the lungs to get oxygenated. If the blood supply is critically reduced, that is why this child is having cyanosis of the central variety. His lips will also be blue, fingertips will also be blue, and even if you give 100% oxygen, the child is definitely going to remain the same. In fact, in the next line diagram, I can highlight what I mean by the word overriding of aorta. Let us take this to be representation of right, left. This is aortic valve orifice, and this is going to be the aorta. Perfectly normal for you and me. The oxygenated blood is able to come into the aorta. When I say overriding of the aorta, in these patients, one, there will definitely be a VSD present. There will also be substantial right ventricular hypertrophy present of the concentric variety, which means hypertrophy is from the inside of the heart. And apart from this, the aorta is also not at the right position. So you can see oxygenated blood going into the aorta, you can see deoxygenated blood going into the aorta. That again explains the central cyanosis component of the patient. Now let us look at when this child will become symptomatic, and I want you to remember that cyanosis on day 0 is not the presentation of tetralogy of Fallot. In fact, if he says cyanosis in a baby on day 0 of life, your first answer is not tetralogy of Fallot. I agree, it's the most common cyanotic heart disease. Your answer would be given as TGA, that is transposition great arteries, that I'm going to subsequently draw before you. But in this particular case, now I want you to look at this diagram and just follow the basic hemodynamics that I explained. The first and the foremost problem that I've highlighted once again is concentric hypertrophy. The second one that I've highlighted is a ventricular septal defect present. You see, I'm saying that pulmonic valve orifice is fine, but before the pulmonic valve orifice, there's definitely this useless muscle. So when the right ventricle of this patient will contract, you will notice some blood will definitely go into the pulmonary artery over the speed breaker, so there will definitely be turbulence. This turbulence will contribute to ejection systolic murmur, because the blood has to go across this gradient of useless muscle in the heart. So at the moment, I have highlighted a concentric RVH. I have also shown this shunt, which is sending deoxygenated blood into the left atria, and all this blue blood, what I mean by blue here is blood that is going to be having low oxygen saturation, is going to race into the descending aorta and into the rest of the body. Now, as I've told you earlier also, that all babies will be born with ductus arteriosus. So I'm going to modulate the diagram here to first show you the attachment or connections of ductus arteriosus. You're aware even from pediatrics that ductus arteriosus will be connecting the pulmonary artery just before it bifurcates into two. Mark my words there. Pulmonary artery just before it bifurcates into two, and the descending aorta. So all this desaturated blood is going to travel via the ductus to the lungs. You can very well notice that in tetralogy of Fallot, though the blood is not being able to go into the lungs directly because of the subpulmonic stenosis component, which I've highlighted in the form of the speed breaker, the blood is after all able to go into the lungs via the ductus also, no? So once this blood will go towards the lungs will definitely do their job and oxygenate this blood and will come into the left side. You can very well see that in the current diagram, because oxygenated blood is finally coming to the left side of the heart, it will actually neutralize whatever desaturation is there, and therefore in these patients, central cyanosis may not be observed on day 0. But the moment the ductus will close, now I'm putting a cross over this diagram to say that the ductus usually begins to close by day 7. The day the ductus will close, then the blood going to the lungs will be only via the subpulmonic stenosis route. Now the blood supply to the lungs is critically reduced. Why? Because the ductus has stopped functioning. As a result of it, the central cyanosis in this condition usually becomes obvious by day 7. Please appreciate, we Indians are relatively dark skinned as compared to Americans. So to see cyanosis in an Indian patient is anyway little difficult as compared to, I would say, a Western or a very fair skinned person. In a patient with tetralogy of Fallot, central cyanosis usually appears on or after day 7. That is when the ductus begins to close. Now, what is the importance of this is that if you have, suppose by antenatal ultrasound, you're already aware that a lady is going to have a baby with tetralogy fillet, like she came for her routine antenatal screening very late, like she came at 24 weeks of gestation or even later 28 weeks of gestation. At 28 weeks, you can't do an abortion. Now she will obviously have to give birth to a baby with tetralogy fillet, because you know in advance that she's going to give birth to a baby with tetralogy fillet. Thanks to the ultrasound technology, you definitely can ensure ductal patency, because the moment it will close, the child will deteriorate. So what drug can be used is what I'm highlighting right now. Though normally I discuss clinical features, investigation of choice, then I discuss the treatment. But here I'm bypassing this because this is an important part of the discussion, that what drug is given in tetralogy fillet in the first few days of life. You see, once the ductus will close, no advantage. You have to ensure that this treatment is given before the ductus will close. So to maintain the ductal patency, the drug of choice that is used in this condition is alprostadil. That's a prostaglandin analog. And once I have ensured that the baby will definitely be able to now grow, because oxygen is going to be there in the body of the child, because at least some blood is going via ductus and is getting oxygenated, we will have to plan a palliative surgery for this child. The palliative surgery is called as Blalock-Taussig shunt. Let us understand what it basically means. In Blalock-Taussig shunt, you will be connecting the subclavian artery. You will be using a vascular graft and you will connect the subclavian artery to the pulmonary artery. Now, what is the big deal about it? The big deal is that I agreed that subclavian artery is having desaturated blood, deoxygenated blood, but it is a high pressure circuit as compared to pulmonary artery. So if you connect a high pressure to a low pressure circuit, blood will go more towards lungs. Please appreciate what is the main problem in tetralogy fillet. The main problem in tetralogy fillet is less blood going to lungs thanks to subpulmonic stenosis. I want to neutralize the effect of subpulmonic stenosis by shunting or connecting the subclavian to the pulmonary artery. So ineffective, what I am trying to do here is, or what in reality I'm trying to do is, I'm trying to increase pulmonary blood flow. The standard presentation of tetralogy of Fallot or any cyanotic heart disease is pulmonary oligemia, less blood supply to lungs. If I increase the blood supply to the lungs, then definitely that would be advantageous. And in the exam, he wants to see whether you are aware of this concept or not. So what will he write? He will say ductal dependent pulmonary circulation. Though I'll give you more examples also, but one of the best examples of ductal dependent, you can see ductus, as long as it is open, blood will go into lungs. So ductal dependent pulmonary circulation, one of the examples that has been studied at the moment is tetralogy of Fallot. Additional features that can be asked for this particular topic, and I'll come back to this diagram in a while, is development of TET spells. Very surprising term. TET spells can also be called as hypercyanotic spells. In this hypercyanotic spells, what happens is that the right to left shunting will increase, and you can very well understand if more blood desaturated will go into the systemic circulation, the cyanosis of the child will actually increase so much that the lips of the child, which are already blue, might even look black to you. I said an extreme thing. I said I'm having a baby who, when he's crying, let me say in the morning, all babies cry, he's hungry, the child is crying and mother is saying, sir, I just got a panic attack looking at the condition of my child. Already I'm so worried about him, his lips are blue. Now they literally turn jet black. And in fact, during this TET spell, they can even be a brain infarction. So let us understand what really is going on. I'll modulate this diagram at the moment. All eyes on the board, please. Please do not note down at the moment and just listen to the information I provide in this diagram. During a TET spell / hypercyanotic spell, this shunting will increase. Now there is limited amount of blood in the right ventricle. You can see more is going towards the left. Because more is going towards left, then ultimately the blood going towards lungs will become even lesser. I repeat my statement once again. There's a fixed amount of blood in right ventricle. If you send more of it to the left side, then the blood going to lungs will also become relatively lesser. This explains the fact why in the textbook it is written that because less blood will go towards the lungs, obviously desaturation will occur, lips will turn black. But over and above this, what's going to happen to the intensity of murmur, guys? If less blood will go, murmur will become softer. So one of the important MCQ statements that I want you to understand right now for a TET spell will be that obviously the mother is telling you the color change of the lips and the general condition of the child is deteriorating. But as you as a doctor, when you auscultate a child during a TET spell, since majority of blood has already gone from the right to the left side, the amount of blood going into the lungs is very limited. That is why the murmur intensity reduces. This has been asked lots of time, guys, in pediatrics. You can call it overlap of medicine versus pediatrics, but this is important that when the shunting will increase, then the blood supplying to lungs will definitely become lesser. So the intensity of ejection systolic murmur in this case will become lesser, or it will become relatively softer. The basic point is, if the ejection systolic murmur is becoming lesser in intensity, the pulmonary oligemia component of the patient is deteriorating. The hypoxia in this condition can be so bad that it can cause death of the neurons, it can cause brain infarction, and a mother might notice that after the TET spell is over, whichever side of the brain has suffered from critical hypoxia, the baby will be moving the opposite side of the body relatively lesser. Neurological complications can develop. So when you read complications of tetralogy fallet, hemiplegia is written how? Because of brain infarction secondary to the hypoxia component. I can give one more reason why there can be neurological complications in children with tetralogy fallet, because there is a constant hypoxic stimulus present in the body. This hypoxic stimulus will contribute to release of erythropoietin in increased amounts. If erythropoietin will be released more, then it will cause more production of RBCs. And if you have taken a blood sample of a baby of tetralogy fallet, the sample will be relatively dark. And at the same time, if you keep it in the syringe, there's a tendency for the sample to clot. Why? Because if RBC count is more, there will be a sluggish circulation. Babies with tetralogy fallet, thanks to the TET spells as well as the standard hypoxia in the body, the combination of the two will contribute to secondary polycythemia. Secondary polycythemia will cause a sluggish circulation towards the brain, and this sluggish circulation can once again explain the neurological features that can develop in the child. So don't be surprised if you read hemiplegia developing in a child with tetralogy fallet. That's definitely a possibility. Why? Because of two reasons: the infarction component and the sluggish circulation. I shall now be teaching you regarding the treatment of a patient of TET spell, and the first and the foremost is that tell the mother not to panic. And maybe most of the mothers, whenever they panic, they'll pick up the baby, put him to the shoulder. I will tell her, ma'am, please do not pick up the baby, rather flex the knees of the baby so that the knees are touching the chest. The first step for management of a TET spell is called as knee chest position. Now the mother is not a technical person, so she's not going to understand the significance of it, but I'll explain to you why am I doing it. You see, when I'll place this baby in a knee chest position, his femoral artery will definitely be compressed. When you kink the femoral artery, then the peripheral resistance will also be increased. I repeat the fact once again, I am causing compression of the femoral artery. So there is an increase in the peripheral resistance of the body, and due to this increase of peripheral resistance, the left ventricle of this baby will now have to apply more force to overcome the resistance. If you increase the pressure of the left ventricle, then the shunting from right to left will reduce. I highlight the fact once again, I taught you during a TET spell, this is the diagram I made, there was more blood coming from right to left. If I somehow, listen to this fact carefully, if I somehow increase the pressure of the left ventricle, I generate more force in the left ventricle, then the pressure of the two sides will balance out and the shunting will stop. And the moment the shunting will stop, the saturation level of the child will dramatically pick up. So how do I increase the pressure in this area? I can increase the peripheral resistance downstream, and that is what I did by placing this baby in a knee chest position. The message is increase the peripheral resistance will contribute to left side of the heart generating more force, and this shunting will reduce and may stop also, and therefore the child will dramatically improve. There is a possibility he may not improve, so there is drug support also. We usually give morphine to these children because we want to sedate them, because at this particular junction, due to critical hypoxia, the child will cry or will try to struggle. Put it on yourself. If you're not getting oxygen and you try to struggle, then your muscles will consume all the precious oxygen and the availability to vital organs will be reduced. So we try to sedate this child and simultaneously handle the metabolic acidosis component, because anytime the child is having hypoxia, the cells are now gonna be going into anaerobic mode of respiration. There would be lactic acid being generated. So to neutralize the acidosis component, because acidosis can damage blood-brain barrier, acidosis can cause arrhythmias, so I can neutralize the acidosis component giving soda bicarbonate. The next drug that I'm using in this case is to increase the systolic blood pressure, that is methoxamine. Now listen to why am I giving methoxamine. If I give methoxamine to this patient, it will increase the systolic blood pressure. If you increase the systolic blood pressure, then the left ventricle pressure will also rise. And if I increase the pressure inside the chamber, you see the point is, if somebody is having increase of systolic blood pressure by 10 millimeter, then left ventricle will have to generate more force to work against that resistance. If I increase the pressure in the left ventricle, it will counterbalance the shunting that was already occurring. So knee chest position / methoxamine are basically doing the same thing. Over and above this, to control the heart rate of this child, I can be using a beta blocker. In tradition, they use non-selective beta blocker for this condition, that is propranolol. Though if you don't have IV propranolol, you can use a cardioselective beta blocker also. In the exam, however, the question was relatively easy. He said, which of the following is not useful for management of a TET spell? The answer is calcium gluconate. Well, calcium gluconate is useful for treatment of tetany, so as such, most people were able to answer this very well. The only point I want to highlight is that what is the importance of using these drugs in this condition? One would be the sedation component, conserve the energy of the baby, conserve the oxygen supply of this child so that I can at least provide more to the vital organs. Otherwise, the bad news I've already highlighted before you, TET spell can end up with brain infarction. In fact, in MCQ, he can mention brain infarction and even polycythemia separately. I've already told you the reason why there is a polycythemia secondary variety, again because of hypoxia. So these are some of the important details that I want you to remember for tetralogy fillet, and because multiple things were discussed here, so I'll try to compile this entire information in a single slide. Tetralogy fillet is the usual cyanotic heart disease which is asked. Examiners love to ask it. So I'm just going to highlight the salient important features once again. This is overall the most common cyanotic heart disease. Now the cyanosis will not occur on day 0. I have already explained that to you because of ductal patency. So in case you get a question which begins like this, he says a baby was born, and he's then going to talk about various informations which are not really critical for the MCQ, like maybe lethargy of the child or not taking feeds properly, but overall is trying to say the baby is blue right on day 0. If it is not birth asphyxia, one is birth asphyxia can also contribute to central cyanosis. The child was born, maybe he cried, he turned pink, or maybe even if not properly pink, he was having acrocyanosis, but that acrocyanosis never went away. In those circumstances, well, central cyanosis in day 0 can be due to a congenital heart disease that will be drawn subsequently, that is transposition of great arteries. So do take a note of that and do remember that information. What I taught you was that tetralogy fillet is overall the most common cyanotic heart disease. Some of the important features that I want you to remember for this condition will be presence of TET spells. In fact, the question will begin by describing a blue baby. Or he will say cyanosis which is non-responsive to oxygen, though the child has been kept in nursery because he was not taking feeds properly, he was a lethargic child and can develop hemiplegia as well. The usual terms written by pediatricians are like failure to thrive. That means because of deficiency in oxygen and the child is not able to feed, he does not have the energy for feeding. That is why failure to thrive manifestation can be given. Now let us look at some of the examination findings for this kid, which will be very, I would say, characteristic of this disease. And one of the important ones is, I would like you to just keep 2 lines vacant if you're noting with me, and first focus on a auscultatory finding. You see, second heart sound is A2 and P2. In this condition, because of the subpulmonic stenosis component, hardly any blood is going towards the lungs, or minimal amount of blood is going to lungs. So the pulmonic valve movement will be very limited, and therefore I've written P2 very small or chota to say that this will hardly be heard. You will be able to hear a normal A2, but you hardly will be able to appreciate the P2 component. So therefore in MCQ he will write the word single S2 is a feature of, your answer would be Fallet's physiology / tetralogy Fallet. In fact, all the cyanotic heart diseases, you will always read about this finding along with ejection systolic murmur that I've already highlighted. Why? Because there's a narrowing. The narrowing is not at the level of the valve, it is just before the valve. But the point is, after all, there is an outlet obstruction, so there's going to be a turbulence created. That is why ejection systolic murmur, he might write the word crescendo, decrescendo murmur, and the intensity of this murmur will reduce every time the child will suffer from a TET spell. I repeat the fact once again. In fact, this was one of the questions in AIMS, currently called as INISAT. They simply said that, which is obviously INISAT is multiple institutes combined, but in a former AIMS exam, they said in a TET spell, what will happen to the following auscultatory findings? Let the correct answer. So it is the intensity becoming lesser. Lot of guys casually marked intensity becoming more. It's not more, it is lesser because less blood is going across. So the turbulence will also be substantially reduced. The additional points for this condition would be obviously visualization of cyanosis and changes in the nails of the child due to long-standing hypoxia, which would be in the form of clubbing. Now, I definitely agree to the fact that clubbing is something that you would be reading with respect to lung cancer, or clubbing is what you see with the, let me say, suppurative conditions like bronchiectasis or even a lung abscess. But from the pediatric domain, yes, clubbing can also be given in this question, or a parrot beak appearance can be present. Now for the workup of this child, I'll be doing a chest x-ray that will be revealing evidence of boot-shaped heart. I'll hand draw before you how the appearance of boot-shaped heart will evolve. So just listen to the inputs that I provide here. See, right heart border is formed by superior vena cava, inferior vena cava, and the right atria. But right ventricle per se forms the inferior surface of the heart. It is going to be towards the diaphragm. Once the right ventricle will enlarge in size because there's a concentric hypertrophy present in these patients, the apex of the heart is turned slightly upwards and it gives a boot-shaped configuration. I want to say that if you focus on the left side per se, this is the aortic knuckle. Then below this, there's the concavity of the pulmonary artery. Then is left atrial appendage, then is left ventricle. What I am saying is that the apex of the heart is lifted slightly upwards. In fact, I'll just highlight that in a separate color so that you are able to actually pick this up in the real exam scenario. The apex of the heart will be slightly lifted upwards. You can see upturned apex. This upturned apex is what is referred to as boot-shaped heart. And whenever there's a left ventricular enlargement, you see this is the area of the left ventricle, then the apex actually goes inferolaterally. In fact, this is itself a question, and it's good that I have spoken about it. I said two aspects. If you get a chest x-ray, simply gives an x-ray in the exam, and you notice that there's a cardiomegaly. Now, cardiomegaly can be due to right ventricular or left ventricular enlargement. He can have both in the options. If you notice that the apex is rather going superolateral, then this is suggestive of right ventricular enlargement. You can see the right is actually pushing the left. So there's definitely a superolateral displacement. In contrast, if you notice that it's going to be relatively inferolaterally, then it's going to be left ventricular enlargement. If you're not able to make out anything, then preferably try to answer as right only. Why I'm saying, because if the examiner wants to trick you, he'll usually give you a right ventricular enlargement. I am highlighting displacement of the apex per se. Over and above the findings that I've highlighted, another thing that you will notice in the chest x-ray will be that it will be unusually black. You see, normally lung blood vessels are well visualized. In this case, there will be pulmonary oligemia. That is why the x-ray looks more black than normal. Another feature will come up secondary to the abnormal arrangement of blood vessels. So right-sided aortic arch. This is itself a term that I want you to remember, because we usually tend to focus only on the word boot-shaped heart. So in the exam, he might be using the following terms. The terms are superolateral displacement of the apex, lungs which are black, that is pulmonary oligemia, and right-sided aortic arch. And to trouble us further, he can even use those Latin terminologies, no, Coeur and Sabot. So boot-shaped heart, I personally feel, is too easy to be asked in a competitive exam. So that is why the examiner will be more comfortable asking these aspects that I have highlighted. Obviously, the investigation choice for any structural heart disease would be transthoracic echocardiography. That will definitely confirm the diagnosis in this case, and then we'll have to accordingly manage the case. What I mean by management domain is that if the diagnosis is made right after birth, even when the child has not turned cyanotic. Why? Because antenatal ultrasound report was there to maintain ductal patency. Alprostadil should be given, but that is not a permanent solution. So to do or ensure growth of the child, we'll connect the subclavian artery to the pulmonary artery. That is going to increase the pulmonary blood flow. That is going to ensure that at least some oxygen is going to reach into the systemic circulation, because more blood going to lungs means more oxygenated blood reaching to the left side of the heart. So that will provide more oxygen to the cells which are starved of that, and therefore the growth in the body would be normal. Please remember, Blalock toxic shunt is not a definitive procedure. It is a palliative surgery that is done in this case. Definitive surgery, the child is not even fit for it. I mean, the anesthesiologist will refuse to operate with respect to the fact that there are 4 defects in the heart. If you try to do definitive surgery when the baby is very small, with a weight of, let me say, 3 kgs or maybe 3.54, he will not be able to withstand the anesthesia for a couple of hours. So initially we do palliative surgery, let the child grow, let the weight of the child become more, let him have that physical capacity to handle the complications of anesthesia, and then subsequently obviously a definitive procedure can be done at or beyond 2 years of age. Most of the time in the exam they love to ask about these aspects of tetralogy phalloid that I've highlighted, so please do try to remember these aspects very carefully. And now look at a very critical thing that I say, and this I'm saying in continuation with tetralogy phalloid because they're going to mix up the two. Now, before I write the name of the disease, because normally I start by writing the name of the disease, you will anyway be forewarned that a new topic is starting. So I don't want you to be forewarned. I just want you to look at the shunt diagram. In this diagram, tricuspid valve is absent. No tricuspid valve. So all the blood that will come in the right side of the heart, that is into the right atria, like this baby is born, so deoxygenated blood will flow into the right atria obviously, but it cannot go in the right ventricle because tricuspid valve is not there. So therefore in the heart of this baby there's a possibility that a window might remain open. This window that I'm talking about will be patent fossa ovalis, and all the desaturated blood will go to the left side. This will be met with oxygenated blood coming from lungs. So yeah, there is a mixing happening in this case. Because of mixing, cyanosis will occur. Well, you can very well understand all this mixed blood, oxygenated and deoxygenated, but after all the desaturation is very much there in the blood, will reach to the left hand side and will cause overloading of the left side of the heart. Please appreciate that when I was teaching you tetralogy phylet, it was a right ventricular hypertrophy, but currently I'm showing all the blood of the right side of the heart is coming by the patent fossa ovalis into the left side, causing overloading of the left. Even this condition will cause cyanosis right at birth. Why? Because this diagram is fundamentally incorrect at the moment, because blood has not gone in the lungs. You see, I showed you blood coming from lungs, that is okay, but has the blood gone in the lungs? So let me now create how will this baby survive after birth. Just like any other baby, this baby has also been given ductus arteriosus by the cord, and therefore you can see that this blood, I'm just going to put two arrows to say that this is desaturated blood. This is going to race via the ductus towards the pulmonary circuit. So at least the blood will be able to go into the lungs. Now I put a crosshair to say that suppose the ductus will close by the 7th day, then no blood will go to lungs and the patient will die on the 7th day. Mark my words there. In tetralogy phylet, I was saying child will become symptomatic on the 7th day. In this condition, 2 points. One, which side of the heart is becoming bigger? Left. Second, the moment the ductus will close, the blood supply to lungs will stop. The patient will expire. The condition, guys, that I've just explained to you is called as tricuspid atresia. The MCQ of tricuspid atresia will also begin by describing us baby with central cyanosis. But one of the key words that will always be written in this question, which talks about a baby with central cyanosis, would be left-sided enlargement of the heart. And they deliberately want to ask this instead of asking about tetralogy phylet, because percent TOF, everybody knows it's a right-sided enlargement. So they put up this question regarding a child. They'll waste your time. Child who's not feeding well, mother is worried about the health, he's not gaining weight, and then talks about blue lips and blue fingertips, then talks about left-sided enlargement. Then don't fall in the trap of the examiner. I've already forewarned you. Your answer would be given as the topic that I've highlighted, and if the diagnosis of this condition has been made before the child is born, then what can you give here to maintain ductal patency? The same drug, no? We can give alprostadil once again for the second time in our discussion at the moment. Alprostadil has been a game changer. It is the preferred drug to be used in the patient in the first few days of life, especially first few hours of life. I'm talking about ductus closing on the 7th day, but what I'm saying is the earlier I start, better will be the chances of survival of this child. So TA/tricuspid atresia, the highlight is left-sided enlargement. At this junction, I also want to bring to your notice another interesting fact for chest x-ray of a patient with tetralogy phylet. Guys, in tetralogy phylet, I have taught you that there's gonna be right ventricular hypertrophy, but the cardiothoracic ratio is normal. Looks surprising, no? On one hand, I said there's a hypertrophy of the heart, so there should be increased cardiothoracic ratio. Please appreciate in tetralogy phylet, the hypertrophy occurs from the inside of the heart, from the endocardial side, and x-ray can't look inside the heart. The surprising thing about tetralogy phylet, remember, and why I'm saying surprising is because the first impression that you get as a doctor is, because we are talking about concentric right ventricular hypertrophy, it is bound to be an increased cardiothoracic ratio, but when you read the textbook, it says normal. So I started wondering what is going on. Is my understanding wrong? Then I found that actually the hypertrophy is occurring from inside. X-ray won't be able to evaluate it. So CT ratio will always be normal. I repeat the fact once again. Cardiothoracic ratio will always be normal in tetralogy phylet, but CT ratio will definitely be increased because here we're not talking about hypertrophy, I'm talking about dilatation. It's a left ventricular failure. I repeat once again, it's a volume overloading of the left side of the heart. It's a failure, it's not a hypertrophy. So even CT ratio might give you a bit of a hint, because you see, if you get an X-ray of an enlarged heart, the impression is it can be right, it can be left. I said whenever in doubt, obviously answer right, because that is what the examiner, I mean, that's just a way that if you're stuck in something where you are not making any sense. But otherwise the point is, if you get a cardiomegaly, it could be right, it could be left. So in those circumstances, if it's going to be a normal CT ratio with the obtained apex, it is boot shaped. If it is increased CT ratio, if it's increased CT ratio and the heart looks bigger, right, because of increased CT ratio, then the answer can even be tricuspid atresia. So the message, the learning point is, guys, I repeat once again, in TOF, the CT ratio will be normal, whereas in tricuspid atresia, CT ratio will be increased, in spite of the fact that hypertrophy will definitely be mentioned by the examiner very prominently, I would rather say, because he wants you to answer as increased CT ratio for tetralogy fault. However, in some MCQs, he might actually love to give you some supplementary information as well. So I want you to listen to that with lot of care. You see, first heart sound is mitral and tricuspid valve closure. But in this case, I'm putting a cross over the T1 value. Why to say? Because per se tricuspid valve closure will never happen, because it's not very much there. On the other hand, I am now increasing the size of M1 by saying the fact that in this condition, because more blood will go across the mitral valve leaflet, because blood is coming from lungs also and from the patent fossa valis also. So therefore, because of more blood present here, the intensity of M1 will increase. So I have taught you right now that in tricuspid atresia, it would be a single S1, but it would be a single loud S1. I repeat the fact once again. Why single? Because T1 is not happening. And why loud is because more blood is going across the mitral valve leaflet, so they will be separated more and they recoil with more force, because elasticity is very much there in the valve, so they get separated more and they recoil back. So therefore they would be a single loudest one. Let's look at second heart sound in this condition. Because no blood is going across the pulmonic valve, here you can see this is where the pulmonic valve is, but blood will never reach the pulmonic valve. So in this condition also, I'm putting a cross over P2 to say that there will again be a single S2. And over and above this, the blood going across the aortic valve orifice might be even relatively more. So it could even be written as a single loud second heart sound, or he might just say single S2. Please appreciate the fact that single S2 is a feature that will be written in almost all cases wherever cyanotic heart disease is present. This is a very good pointer in the MCQ where you read single S2. It means that there is less blood supply across the lungs, in especially pediatric questions. And if you read single S2 with the single S1 also, because you see there are two things. No, loud per se is something that is difficult to appreciate, especially if the child is small or if the child is crying or if there is a noise of the monitors in the NICU. So what I'm trying to focus upon here would be that if you are not able to appreciate the intensity, the single part or the splitting part can definitely be appreciated on careful auscultation. So single S1 and single S2 will also give credibility to the diagnosis, though obviously this is a additional information. If it is given, great. Even if it is not given, you should be able to solve the question based on presence of central cyanosis in the baby on day 0 along with left-sided enlargement of the heart. You again notice an additional point I said, day 0, guys, tricuspid atresia will become symptomatic on day 0 because there is no blood supply to lungs except the ductus. So severity of hypoxia is so severe that the manifestations will begin on day 0, whereas in tetralogy fallet, at least there were 2 exits for blood reaching into the lungs. Look at this diagram. In tetralogy fallet, there were 2 exits of blood going through, one via the ductus, one via the subpulmonic stenosis. In tricuspid atresia, there is only one way for the blood to reach. That's the reason why the child will become symptomatic earlier. In TOF, there are 2 ways by which blood can reach the lungs. So at least some oxygenated blood will come to left side. In tricuspid atresia, there is only one method of blood reaching the lung. That explains the fact, I mean, why this disorder is more critical. I mean, the criticality of the disorder can be understood from the line diagram that I made before you. We will now compare this information with that of TGA, that is transposition of great arteries. So I'm going to draw a line diagram before you, and I would suggest you to make with me, especially for this particular disorder, because I usually find people getting confused about TGA in the exam. See, the first and the foremost thing I want to highlight is that in these patients, this is the right ventricle, this is the left ventricle. It is aorta attached to the right ventricle. In red, I have highlighted the aorta of the patient. And unfortunately, The pulmonary artery, which has been shown to be bifurcating into two, is hooked up to the left ventricle. That is why we need to do a switch operation in this case. Now, get the blood vessels to the right position. Now, let us track the flow blood in the body of this patient. So, all the deoxygenated blood is racing into the right side, just like it would happen in any one of us. Then it will go into the right ventricle. But now, this deoxygenated blood via the aorta will again be going back to the body. The problem in transposition great arteries is that all the deoxygenated blood is circulating between the aorta and the right side of the heart. Whereas when it comes to oxygenated blood coming from the lungs per se, then this oxygenated blood will enter into LA, LV, pulmonary circuit, and then again the same thing is repeated. Guys, I'm teaching you a condition where there is a parallel circuit in the heart. The deoxygenated blood is circulating in the right side of the heart, oxygenated blood is circulating in the left side of the heart, and the query that comes up immediately is that how did this blood reach the lungs in the very first place? You see, the blood can definitely be understood, it is circulating in the right side. For the left, it has to go to the lungs. No, there is no way by which the blood has gone into the lungs. So, well, sometimes God might be kind on this child and may give him a ASD. This ASD will allow mixing. Sometimes God will be more kind and will even give him a VSD. Imagine a child with TGA, he's having ASD also, VSD also. This will cause mixing of the two circulations. Mixing will explain the sinuses component that will become positive on day 0. And over and above this, this child will also be having this anatomical structure I was talking about, ductus arteriosus. So let us also draw this ductus arteriosus from bifurcation of pulmonary artery to the descending aorta. Now, what will be the flow of blood in this ductus arteriosus? Will it be from the pulmonary artery to aorta, or will it be from the aorta to the pulmonary artery in this baby after birth? Well, you can see that the pulmonary artery is connected to left ventricle. Left ventricle generates more pressure than right ventricle, na? So more pressure of the left ventricle will send this oxygenated blood. You can see this oxygenated blood traveling via the ductus arteriosus into systemic circulation. So you can see that ASD, VSD and ductus arteriosus are methods by which the circulations can be mixing, and ductus arteriosus is the reason how oxygenated blood is reaching into systemic circulation. Otherwise the patient would have died. There's a high probability of TGA patients dying even after birth because obviously the oxygen supply is limited by ductus, and ductus is going to close by the 7th day. So therefore, once again, I have talked about a condition where if I give alprostadil to the patient, if I maintain ductal patency, you will notice that oxygenated blood will be able to go into the systemic circulation. No, in fact, I repeat my facts once again, guys. Please appreciate that in a person who's having transposition of great arteries, the way I've shown before you, the blood is gonna go not from the aorta to pulmonary artery. Normally, we think aorta pressure is more than pulmonary artery pressure, but look at this guy. The pulmonary artery is getting feed from the left ventricle. That again explains the criticality of the disease per se, that pulmonary artery is being fed from the wrong ventricle. As a result of it, the performance will definitely, the pulmonary artery will suffer because it is connected to a high pressure circuit. So the treatment of choice for this condition is switch operation, where you need to put this patient on cardiopulmonary bypass and connect the pulmonary artery to the right ventricle and aorta to the left ventricle. Easier said than done. But the message at the moment is, once again, for the third time in this discussion, I have said alprostadil should be used. Till now, I have taught you alprostadil for tetralogy fallet. Alprostadil should also be given to patients who are having tricuspid atresia. Why? Because it will maintain ductal patency, so at least blood will continue to go into the lungs, and so is the case with respect to transposition of great arteries as well. Over and above this, some additional information can also be put up by the examiner in the question, so I'll just mention that additional information also. If that is given, great. Radiological finding of this condition would be called as egg on side appearance. I can mention related MCQs here also. Easy one first, eggshell calcification. You read that 2 times. Eggshell calcification is read in sarcoidosis and most common occupational lung disease, silicosis. Next is egg in a, listen to the word carefully, egg in a cup appearance. Yes guys, egg in a cup. That means there's a calcification outside the heart. No, that is going to be constrictive pericarditis. So a couple of egg-based questions is what I try to squeeze in here. And for transposition of great arteries, initial management that we use or initial treatment that is done is alprostadil plus atrial septostomy. We deliberately create, if ASD is not there, if ASD is there, great. But if ASD is not there, we deliberately cause local destruction in the interatrial wall. Look at the extreme thing that I'm saying, that if ASD is not present, atrial septostomy will be done to allow mixing of blood between the two circulations. I have created a good scenario for you guys. Let me say the baby is having ASD, VSD and ductus also. So there are three methods of communication. If there is gonna be, let me say, only one, that is no ASD, no VSD, only ductus arteriosus, the day it closes, child will die. In tricuspid atresia and TGA, the criticality is if ductus will close, the patient will expire. But in tetralogy of Fallot, the ductus will close, it will not result in death, it will cause presentation of cyanosis. That's the difference I want you to appreciate. Let us now focus on the next congenital heart disease. I will be writing the name of this condition in few seconds from now. At the moment, please focus on the line diagram. The patient is having a single ventricle. There's no demarcation between the left and the right. Yes, the right atria is in place, the left atria is in place, but then coming out of the single ventricle is a single blood vessel. There is no aorta, there is no pulmonary artery per se. There is a single vessel which is bifurcating into two. I can say this heart is like a frog's heart, where one blood vessel is going to the systemic circulation and another one will be supplying the lungs. Well, if it is deoxygenated blood, I can just highlight that with blue color. If it is deoxygenated blood that is coming in the right atria, in this case it would be oxygenated blood coming into the left side, and then obviously it will mix. So that mixing is one explaining the cyanosis component. Moreover, all this blood, which is a mixture of the two but will be desaturated blood, will race into this common blood vessel and then will be distributed to the body and will be distributed to the lungs as well. As such, in this condition, I have not shown any per se, I have not highlighted any aorta or pulmonary artery. Well, I presume you should have guessed the name by this particular point of time. The disease that I'm teaching you is called as truncus arteriosus. Now you will realize why am I teaching you this condition, because he's having central cyanosis. So I have learned till now that if a baby will have central cyanosis, we should be giving alprostadil. But in this condition, even if I give alprostadil to the child, he's having central cyanosis, my first thought process is start alprostadil for ductal patency. But there is no ductus arteriosus in this condition per se present in this condition, guys. Why? Because there is no aorta, no pulmonary artery. So even if you give alprostadil, it will not cause any benefit to the baby. Alprostadil is currently being taught to you as being contraindicated in the condition referred to as truncus arteriosus. In couple of questions, instead of writing truncus arteriosus, he might write the word co-truncal abnormality. The bottom line is three conditions where we have found alprostadil to be life-saving is tetralogy of Fallot, tricuspid atresia and transposition of great arteries, but there is no role of alprostadil in truncus arteriosus. Let's try to learn one more disease now, and again I'll draw a line diagram before you initially rather than telling you the name right away. In this case, at the moment per se, the development of atria and ventricles is fine. We have a right atria, left and the right ventricle respectively. This is the pulmonary artery also. So it's bifurcating into two just like a normal person. So far so good. The deoxygenated blood that will enter in the right side of the heart of this person is going to right ventricle like you and me, going into pulmonary artery like you and me, racing towards the lung like a normal person. So far so good. At the moment, there is absolutely no problems. The lungs are supposed to oxygenate the blood and send it to the left atria. This is where the problem is. You see, I have just put 4 lines here to say that there are 2 pulmonary veins from each lung. That would be total of 4 pulmonary veins. What I am saying is that in the current condition we are discussing, these pulmonary vein segments are atretic. Well, by this juncture, you would be aware of the name of the condition. I'm teaching you total anomalous, that is abnormal pulmonary venous correction. In a patient of TAPVC, the pulmonary veins that I have highlighted at the moment, these segments have not developed. So blood will definitely reach the lungs. The problem is that when the blood will reach the lungs, where will it after all go? So these patients tend to have an abnormal blood vessel that I'll represent in a separate color. Now I'm here showing obviously a single abnormal blood vessel. It would be one from each lung. This abnormal blood vessel will carry the oxygenated blood back into the right atria of the patient. Look at the surprising thing, guys. The blood went into the lungs, that is fine, but then came back into the right atria of the patient. So the problem in this patient is that ideally the blood which is oxygenated should come in the left atria, but in this person, the blood, because the pulmonary vein segments are atretic, it has come back in the right atria. That explains the mixing component, and then God usually gives these patients an ASD. This explains why during my discussion of ASD also in heart sounds I have said that TAPVC can be associated with ASD. So even in TAPVC, wide fixed split second heart sound would be written, and now this blood will be able to get an access. Obviously it would be a mixing, but this blood will be able to get access to the left side of the heart, and once it gets access to the left, then it can go into the systemic circulation as well. I basically wanted to teach you that in total anomalous pulmonary venous connection, all the blood is after all coming into the right atria itself. So the mixing is happening in the right side of the heart. Now, because of this mixing, obviously there will be cyanosis in the child, and I have been taught and I have learned that whenever a baby is having cyanosis after first or second day of life, or even as early as few hours of life, and that's because of a congenital heart disease, we should give alprostadil. So this is ductus arteriosus, like would be present in any child, and I have given alprostadil to the child. Let us see what advantage or disadvantage will it cause. If you start alprostadil in total anomalous pulmonary venous connection, hoping that it will correct the cyanosis, it will obviously maintain ductal patency. So all this blood, I'm just putting two arrows here to say that this is desaturated blood coming from the left side into the systemic circulation. This blood will definitely be able to travel across this anatomical structure, that is ductus arteriosus, towards the lungs. But after all, once it will go to the lungs, it will again come back to the right hand side. Please appreciate, guys, in if you give alprostadil to this particular guy of TAPVC, you will not be able to improve the cyanosis, because blood is after all still going to lungs. Even if you're not giving alprostadil, problem is of blood coming back, and alprostadil is not going to ensure that the blood is going to come back. This abnormal blood vessel or blood vessels that I've highlighted are not going to be affected by alprostadil. All you are ensuring rather is the worsening of the patient, because there is already a stressed out right side of the heart. You can see the right atria of this patient is already receiving more blood. If you keep the ductus open and ensure more blood to rush into the circuit, it will cause, I would say, dilatation of the already stressed out right atria, right ventricle of the patient. Alprostadil is contraindicated for the second time today. Why alprostadil is contraindicated in this case is because it will cause overloading. You can see already when I had drawn the diagram, there was overloading of the right atria. Now there is overloading of the stressed out right side of the heart. There is overloading of the right chambers per se, because of which it will not give any survival advantage. Usually in the exam, after alprostadil concept, they also love to ask about anatomical variants of it. I had represented in color green a abnormal vein present in this patient, or veins present in this condition, which was entering into the right atria. But it is a possibility that in some cases, the abnormal vein may not enter into the right atria, but might enter into the superior vena cava. In fact, the abnormal vein that I drew could also be entering into inferior vena cava. I'm now trying to teach you that there are a couple of variants of TAPVC that you will read as supracardiac, cardiac, and infracardiac variety. You can see the reason why it is coming up. If the abnormal vein, I'll just bring that vein into focus once again. This one in green, this was the abnormal vein coming from the lungs going back to the right atria, not to the left atria. If this abnormal vein is looping and is entering in the SVC, then it is supracardiac variety. If in the right atria, it is the cardiac variety, and if in the IVC, it is going to be the infracardiac variety. Once you get these names right, I also want you to remember that overall the most common variety is supracardiac variety, in which the vein will have to loop across and enter into the SVC. Because of this, the shadow of the heart will be also having a shadow of the vein that is looping above, and therefore the classical finding of figure of 8 or snowman heart that you read is valid only with respect to the supracardiac variety. I repeat the fact once again, guys. When you read figure of 8 appearance snowman heart, it is obviously TAPVC, but with which variety will it be seen? Your answer will be the supracardiac variety, because this is the only one where the vein looping above the cardiac shadow. This is the cardiac shadow, this is the heart shadow per se. So over this, the abnormal vein loop shadow would be present. The additional aspect that I've highlighted is that lots of time TAPVC can be associated with atrial septal defect. So wide fixed split second heart sound, when you read the literature of wide fixed split second heart sound in the heart sound component, I have mentioned about this pediatric domain as well, that not only ASD but TAPVC per se can be associated. Other ones that I've highlighted are like Holt or arm syndrome. Holt or arm syndrome would be having skeletal defects with ASD, but the bottom line is wide fixed split second heart sound is again something which our examiners love to ask, so you should be more comfortable about reading those aspects. In the next line diagram, I'll be focusing on defects in the left side of the heart as compared to what I was highlighting for pulmonary circulation. Now I'm going to talk about the systemic circulation getting hampered. At the moment, I've drawn a normal diagram showing open mitral and the tricuspid valves. The bad news in my case is that the aortic valve is not present. The case that is being discussed at the moment is having problems with his left-sided circuit, that is aortic atresia, and as a result of it, you can see that whatever blood left side of the heart will be having, the oxygenated blood will not be able to reach into the aorta. If oxygenated blood is not able to reach into the aorta, this newborn baby on day 0 itself will become symptomatic and will again develop central cyanosis. I taught you central cyanosis, the leading cause is transposition of great arteries, but even in aortic atresia, the central cyanosis component will come. The difference from tetralogy fillet or transposition of great arteries is that there the problem was with respect to circulations. Here, aortic valve itself is not there. So because the child will not receive any blood supply, he will also go into shock. And this shock is explaining why there is a cyanosis, because if the cells will not get oxygen, they will be depleted of oxygen, they will switch to anaerobic mode of respiration, and that is when the cyanosis component will start coming in, lactic acidosis will start coming in, and the child will die within few hours of birth. Well, let us see, can this child be made to survive beyond a few hours? I'm not saying that I will make this child live. All I'm saying is that if parents agree, we can at least increase the longevity of the child. We cannot correct this condition definitely unless and until cardiac transplantation is available. Then it's a different issue, and that is what I'm aiming for. Why am I trying to prolong the life of this child is that if a cardiac transplantation, then if a age matched donor is available, we can do a cardiac transplantation. Otherwise the patient is anyway gonna die. So to buy those few hours, what I can give or do in this patient is I can still give alprostadil. Now see what will happen. See, the pressure on the aortic circuit in the aorta will be lesser than that of the pulmonary artery. Why? Because blood is not coming in the aorta per se. So because of this pressure difference, the ductus will operate like this. The ductus will ensure, or ductus will send at least some blood from the lungs. No, in fact, I want to highlight the fact that traditionally the ductus will operate from aorta to pulmonary artery, but in this condition, it is operating from the pulmonary artery side to the aorta. Why? Because the aorta side is not receiving any blood from the left ventricle. So the pressure of the pulmonary artery is relatively higher. So this extra flow that will happen in the systemic circulation might prolong the life of this guy. This condition that I've highlighted before you is called as aortic atresia, and the reason why it has been discussed is that again alprostadil has been found to be useful in buying a few hours for this child, and I would like to call this example of aortic atresia as ductal dependent systemic circulation. If you are listening to me carefully, in the earlier part of the discussion, TOF, tricuspid atresia, I was saying the word ductal dependent pulmonary circulation, but now I'm saying the word ductal dependent systemic circulation, and the first example of that would be presence of aortic atresia. Let me just draw this again. If I erase it and I draw it, it will become a little untidy and messy for you. So I'll just do the hard work of doing another sketching here. This is the aorta. This is the bifurcation of the pulmonary artery once again. My patient is now having a very peculiar disease that I'm rephrasing. This is called as interrupted aortic arch. There is a malformation in the aorta. Because of this interrupted aortic arch, I can therefore say that hardly any blood will be going into the systemic circulation. In the previous condition, I was showing aortic valve atresia. Currently, I'm showing is a interrupted aortic arch. Now, obviously, complex surgical procedures are available even for this particular case for management. But if I want to ensure survival of this child for a few hours, what I can do is I can still once again allow this ductus to function, because anyway it starts closing after birth and functional closure occurs by the 7th day of life. If I will keep this ductus open, then at least some pulmonary artery blood will be able to flow to the aorta side. Why the aorta pressure will be less is hardly any blood is going across this interrupted aorta or interrupted aortic arch per se. So end result is that ductus will be, if kept open using alprostadil, the survival of this child can definitely be ensured. So I have described a problem in the left side of the heart where alprostadil is useful. This is another example per se of ductal dependent systemic circulation. Let me just go back to the previous diagram, guys. Aortic atresia, interrupted aortic arch. The basic common thing between the two is blood is not going in the aorta. Aortic pressure is less than the pulmonary artery, so L-prostadil will be beneficial. And now I can actually make a list before you of conditions where I have talked about ductal dependency. And I have said ductal dependency per se for pulmonary and systemic circuit. Lots of time in the exam, they definitely like to ask for systemic circuit, because for pulmonary circuit, they know that you will study it in your UG also. In the systemic circuit, we will go retrograde from the aorta. The first condition I taught you was a problem in the aorta. This is different from coarctation of aorta, guys. Coarctation of aorta is a single narrowing. No, here the multiple narrowings present. So the blood to navigate across these multiple obstructions will be very limited. So interrupted aortic arch. Then if I go back towards the aortic valve has not even developed, so all the hard work is lost, because oxygenated blood of the left ventricle will not go into systemic circulation. Let's go a little backwards. The left ventricle is not developed. Valves are okay, aorta is fine, mitral valve is fine, aortic valve is fine, but the patient is not having substantial muscle in the left ventricle to pump blood. The condition is hypoplastic left heart syndrome. Again, in this condition, I can say though complex surgical procedures can be done, / we can go in for age-matched cardiac transplantation. Even in this condition per se, I can say that ductus will at least help to prolong life for a few hours. At least some blood will go from pulmonary artery to systemic circuit, because left side of the heart is not doing the job it is supposed to do. Another worst case scenario for you, person is having mitral valve atresia. Now I agree that these diseases are going to be very rare and lots of time babies are going to die after birth. But the point is, even in mitral atresia, because the blood is not going to reach into the aorta, the aortic pressure will be lesser than the pulmonary artery. So if you ensure the ductal patency, if you ensure that you give L-prostadil to these patients, at least few hours extra can be ensured, and by that time maybe a cardiac transplantation may be achieved. In contrast, ductal dependency for pulmonary circuit was discussed with respect to tetralogy of Fallot and then tricuspid atresia. I hope you recall in tricuspid atresia, it was a single S1 and a single S2, whereas in tetralogy of Fallot, it will always be a single S2 present. Now he will use English and he will say ductal independent lesions. So this is, I would say, just playing around with English by the examiner. Ductal independent lesions would be like Kawasaki disease. Kawasaki has coronary artery vasculitis. Coronary artery vasculitis has nothing to do with L-prostadil infusion. Similarly, when I say independent, there is no advantage of giving L-prostadil in total anomalous pulmonary venous connection. Why? Because I explained to you, the abnormal vein was looping back into the right side of the heart. So even if you keep it open, or even if you keep the ductus open, it will not give any advantage. There will be overloading of the pre-existing load present in the right side of the heart. And so was the case with what I casually said of frog's heart, in a sense that there was a single ventricle and there was no aorta, no pulmonary artery, single blood vessel bifurcating into and supplying both the lungs as well as the body. That is referred to as truncus arteriosus, or rather most examiners prefer to use this word co-truncal abnormalities. This is a slide that I would definitely like you to practice by yourself. Please note it down on a stick-on pad, and whenever I give you these inputs, guys, I would definitely like you to act on those, because I usually find, people tending to forget this, but once you get the orientation right, and how's the orientation? Think about obstructive lesions in the left side of the heart, which are going to prevent the blood supply into the aorta. Talk about conditions where there's going to be subpulmonic stenosis, that's going to be the pulmonary circuit. The independent ones are relatively easy, where I just highlighted that the examiner is more trying to play around with English language only. Now consider the last line diagram before I actually summarize everything that I've said in this particular topic. Since you have studied this from pediatrics, I think that overall congenital heart disease topic will be easy for you. I know that it takes a longer time to cover, but then the yields are also good, that if they give you questions on pediatric cardiology, you should be able to score. Now I'm describing a baby who's born to a mother taking lithium. Like, she is a patient of mania depressive psychosis and she's on lithium and she had pregnancy, accidental one maybe. As a result of it, the baby can develop Epstein anomaly. One of the fundamental problems in Epstein anomaly will be inferior displacement of the tricuspid valve. You can see the position of the mitral valve, you can see the position of the tricuspid valve, and what is the direct implication of this will be that because the tricuspid valve is inferiorly placed, therefore the right ventricle is relatively smaller, and lesser muscle mass in right ventricle will mean that the blood going into pulmonary artery will be lesser, and if less blood will go into pulmonary artery, that explains the cyanosis component. I repeat the fact once again. One of the big problems in these patients is right ventricle size is relatively smaller. Why? Because there was an inferior displacement. In fact, that's the MCQ statement. Epstein anomaly has inferior displacement of the tricuspid valve. Overall, the size of the right ventricle will be relatively smaller, so less blood is going to lungs. Pulmonary oligemi as explained. Over and above this, additional problems that can be also seen in this condition is concomitant tricuspid regurgitation. Now let us see what's going to happen if there's going to be a TR also. That means tricuspid valve is not able to do its job properly. So if the blood will leak like this during the phase of systole back from the right ventricle, obviously the right ventricle muscle mass is lesser, but if the valvulate is not competent enough or is rather having insufficiency, the blood will leak back into this relatively big RA and will increase the pressure in the RA. I have put two pluses in the RA at the moment. One plus is to highlight bigger right atria means higher pressure. Second, the regurgitation of blood will also contribute to higher pressure. So no big deal that lot of these babies might even be having a concomitant patent fossa ovalis. And now you can see that due to higher pressure in the right atrium, thanks to two things. One is the bigger right atria. Second is presence of tricuspid regurgitation in this condition. The deoxygenated blood that will come in the right side might actually move across to the left side, and that will explain the mixing component also present in the heart of these patients. Well, let me just enumerate what are the problems of this patient of Epstein anomaly. He or she is born to a mother who was taking lithium. The first problem of this patient is right ventricle is smaller in size, so less blood will go into lung sinuses. Second problem is right atria is bigger. Higher pressure of right atria will cause fossa ovalis, will actually prevent the closure of fossa ovalis, because normally it should close after birth, but in this particular case there is a PFO present primarily because the pressure in the right atria will be more than that of left. In you and me, the pressure of the left was more than that of the right. That is why everything closed. That is the connection between the left atria and right atria in a baby which is present before birth will close in a normal child, but in this condition due to pressure difference will remain open. Over and above this, add the insult of tricuspid regurgitation. So this that I've described before you is Epstein anomaly. Now there are two aspects which I want you to remember for this condition. One is the inferior displacement of the valve that I've highlighted, and the next one is the presence of Wolff-Parkinson-White syndrome. Now, WPW syndrome is what I've discussed in ECG and arrhythmias, where we read about a delta wave. But the question that came in the exam actually was a pure pediatrics one. The question said WPW is associated with which congenital heart disease? I repeat the fact once again. The question was WPW is associated with which congenital heart disease? Your answer will be given as Epstein anomaly. And it is mainly to cover this question that I have touched upon this pure, I would say, topic, which is also taught in pediatrics as well. So let us just do a quick summarization here with respect to the various diseases we have studied in a single slide. I will mention regarding left to right sided shunts, right to left sided shunts, and then we have mixed defects also. You see, left to right sided shunts will always be having congestive heart failure with features of recurrent pneumonia. When it comes to right to left sided shunt, there will be cyanosis with failure to thrive. Mixed defects would mean that this would be combination of both. The defects that I've written in the MCQ, cyanosis will also be written and congestive heart failure will also be written. So let us enumerate the names now. For left to right sided shunts, the diseases to be remembered is VSD, ASD and PDA. The comparison of them has been done with respect to the heart sounds already. For right to left, it would be tetralogy of Fallot, tricuspid atresia, and then Epstein anomaly. Epstein per se is asked primarily for two reasons: association with lithium, WPW, inferior displacement of the valve. The mixed effects which are to be remembered are transposition of great arteries and total anomalous pulmonary venous connection. In fact, lots of time they might ask you radiological findings of these, which you can fill up here, like egg on side appearance. TAPVC will have a figure of 8, but only valid for supracardiac variety. One of the special findings for right to left sided shunts will always be a single S2. In fact, auscultatory finding I can mark with a different color here so that you can remember it. Whereas I have discussed already the permutation combinations of S2 with respect to VST as well as AST. Both would be wide. VST is wide variable, AST is wide fixed, and patent ductus arteriosus will be rather a narrow split one. Over and above this, he can also ask you about obstructive defects. One of the obstructive defects which is even more distal in the aorta is coarctation of aorta, which has been discussed separately in the murmur section. In coarctation of aorta, there are various reasons patients will come to you. Later presentation will be obviously because of left ventricular hypertrophy, because there's an obstruction present, so left ventricle will have to work harder than normal. But initial presentation why these patients will come to you is because there will be less blood supply. One of the reasons why these patients will come will be because the person will be wearing socks in the summer season. Why? Because the patient's toes will feel relatively cold, and that's because of less blood supply to the legs, and BP of the legs of these patients will also be lesser. I repeat the fact once again. Patient is saying my friends make fun of me because I wear woolen socks in summer season. Why? Because if blood will go less to the toes, then there will be maybe pallor and even icy cold sensation. So person is not a medico or is understanding that there's a less blood supply. He is wearing woolen socks in summer season. If you check the BP of this patient or coarctation of aorta in the upper limbs per se, the BP will be relatively higher. So you need to remember these conditions that I have highlighted with respect to structural defects that can occur. And in America, they have been smarter than us in a way that they have reduced or the caseload by increasing the age of abortion. India has also passed a law for the same. You see, congenital heart diseases are best diagnosed between 20 to 24 weeks of gestation. And by that time, you see, already in India, the upper limit was 20 weeks only, and congenital heart disease is detected later. So there was a lot of litigation where a lady, let me say 24 weeks of age, when she was told that she's having a baby with any of the following lesions, she approached the doctors refused, so she went to the court, and the court was having so many rather requests from ladies who said, I have this is my body, I have a right whether I want to give birth to a defective baby or not. So now they have increased the age of abortion to 24 weeks like is present in America. Because of that, more congenital heart diseases will be diagnosed before they are born, and therefore if you abort these defective babies, then obviously congenital heart disease load in the country will dramatically reduce. I want you to go through the technical aspects of each one of these diagrams, and if you can just draw those line diagrams, then you will be relatively more comfortable to answer this particular section that can be asked. And obviously it has overlap with pediatrics, so ma'am has done a wonderful job talking about all these diseases even there, and if you can combine the two, even then you would be able to enhance your strike rates as well. Thank you so much for hearing. Keep hammering, keep learning.